Good morning. How are we this morning? Isn't it a beautiful morning? Isn't it nice to be with fellow prostate cancer patients? Huh? We're going to have a good day today, and the subject is what do we do when we find out our cancer has returned? How many have had their cancer returned? Just raise your hand. Look at that. You got a hot audience here, Doctor. Okay, welcome. We're very fortunate to have the Sanford Burnham Prebys auditorium here. It's in use for other events and not just ours, so help us keep it clean. And in terms of facilities, we have the facilities out in the back door and then down, it seems like a quarter of a mile, particularly if you're in an urgent state. That's there. Please shut off your cell phones. Some of us are hard of hearing and don't notice, but it does interrupt and irritate some of the others. And let me look at show you these are all the volunteers, there's 10 of them, that make this program work. And they all have prostate cancer for a huge number of years. Now we have, for Bill Bailey, for Bill Manning, we have another Bill back here with the camera. And welcome, thank you. So if you'd like to have, these are all happy prostate cancer people, and they're happy because they're volunteers. And so if you want to get happy, come talk to Gene or me about volunteering. This is not an easy endeavor to put together. It requires a lot of people dedicating time to it. So we're open to volunteers. Okay, newcomer package. Newcomers, did you get the yellow form? Did you get that? If you haven't got it, there we go. And now please fill out the yellow sheet. And we'd like to have that because Gene would like to give you a call next week and welcome you and see if you have any questions. And it can be very helpful to you. Okay, what's the purpose? This is a support group. It's not a medical conference. This is a support group. We're here, it's a patient support group. Most of you are patients. We have doctors come in and provide some background knowledge and some expertise. This is a special place for that. And as you well know, we get doctors from all over the area, and not just San Diego. And guess what? The doctors love to come here because guess what they think? They think you're a very knowledgeable group. Can you imagine that? They like your questions. So we're going to open up after the end of the talk for questions, and I will lead that, and we'll just scan the group as we go, so you'll have plenty of time to ask your questions. And that's the big benefit. But please don't ask to get an instant El Cheapo diagnosis from the speaker. They're not prepared to do that. But this group of speakers and attendees and anything you hear is not a replacement for your doctor. What we hope we do here is raise questions that you might want to ask your doctor. And ask them, why don't we do this, how about that? And frequently what I find out is, yeah, we could do that. And in some cases, until you bring it up, they don't think of it. So anyway, we're not a substitute, but I think a very good source for information. Here's what we provide you, is a website. Our webmaster is back there. That's Sean Tassi. There he is. And then we got a library and books and papers. And now it's out in the lobby because it started to get jammed up with speakers trying to answer questions up at the podium. So there's some really good stuff. Some is free. Some you can rent and bring back for the next meeting, and some you can buy. Like you can get the newsletter free, and you get the DVDs. If you missed the meeting last month, there's a $10 DVD, and we make a couple of bucks on that, which we could always use. We have an outreach for new members. The core of this group is getting new members, and you're a participant in that program. We have brochures out there. Pass it among your friends. You know, if you got 6 friends your age, one of them's got cancer, prostate cancer, besides you. That's the statistics. And then share the newsletter, but the brochure is a good calling card for you. And if you belong to a club, a men's club or Rotary or whatever, and would like to have one of us talk about the program, we'd be happy to come and join you in talking about that. And we have, as you well know, monthly meetings. The next series of speakers, we're going to find more about what's new in surgery from Dr. Kane from UCSD. And then next month after that, Dr. Rossi on an update on proton therapy. So keep us in mind, we're the 3rd Saturday of each month. Okay, let's do our traditional survey. This is for the newcomers and our doctor. Please raise your hand high. How many are here for the first time? Well, welcome, welcome. I think you're going to benefit this, and I hope to see you come back. How many have been recently diagnosed in the last 6 months? Raise your hand, please. I'm sure, like you, it was a shock, and not knowing what's going on, and it's a very complex disease, and there's no one treatment for it. There's up to 16 different treatments. What's the most appropriate? How many have had prostate cancer up to 1 year? You're still working on it. Now watch the hands go up now. How many have had it up to 4 years? 4 years? 5 to 10 years. Look at that. See, if you got 1 year, look what you're going to have. You're going to have to come back here all that amount of time. Is that something to look forward to? 11 to 15 years. See? And now, who's got more than 15? Okay, now, okay, Jack, are you there? How many? How many years? 28. Anybody higher? Okay, you're still the grand award winner here. Okay, so you can deal with it, and okay, let's do a treatment survey. How many are now on active surveillance prior to having treatment? Active surveillance. How many have had surgery of the prostate of all kinds? Okay. Now, how many have had radiation? See how many more now. See how many more we're getting with radiation as opposed to surgery. How many are on ADT hormone therapy? Okay. Now you notice Gene here, he's had all these. And he'll keep raising his hand here. How many are on chemotherapy? Chemotherapy. How many we got? We got 1, 2, one used to be, one who used to be there, that's 3 and 4. Okay, new treatments, all these new treatment, Xtandi, Zyfigo, apalutamide, and so forth. I'm on one of those, Gene is. Yeah, see, we got the, and as I already asked you, but let's see it again, how many have had recurrence? See, that's the situation with prostate cancer. The good news is when you first got it, there have been a lot more treatments available to you for different situations. How many are undecided what to do next? Okay, yes, and we hope you pick up some ideas and some questions you to ask your doctor. Okay, guess what? It's money time. In order to make this thing go, we need some money. And this is not a dollar meeting. This is, if you want to know the average we need to keep going without dipping into our reserve, we need $10. We like bills with zeros on them. And if you got some bills with 3 zeros, that's fantastic. Give it to me and don't put it in the basket. No. If you can pony up $10, we certainly appreciate that. And so if we can get the baskets going, could you get the baskets going on your aisle over there? And Tom's going to get it going down here. And so there we go. Just pass it down the row. Pass it down the row. Okay. And we're tax exempt. So come next April, you'll be regretting that you didn't give more. So give what you can. And okay, while that basket's going around, here's the 6 principles we have. Our approach is you must manage your own case. The doctor has many cases, but you're the best one to manage your own case because you know what quality of life aspects, what hurts and what doesn't hurt and things like that. So you got to manage your own case. Should you get another PSA? And so here are the 6 ingredients. One is early detection. Second is using high-definition diagnostics. We're going to hear about some of that. And that's so you get a targeted biopsy. So they're able to see the tumor and put that needle right into that tumor as opposed to the random, which most urologists do down here. There's the 12 cores that go in there, that can miss the tumor. Next is the know your Gleason score. Everybody know their Gleason score? If it's a 6 or a 7, you're a prime candidate for active surveillance. You don't need, at this point, an invasive surgical or radiation technique. Talk to your doctor about that. Once you know that, then you get choices. And the last thing is you got all kinds of treatment options, what works for you. One of the things that I've run into, I'm going to add to it, most of the treatments, particularly ADT, cause side effects. Most people get at least one side effect. Some get almost all. I'm one, I guess jokingly, because I'm Swedish. I'm not Irish or Italian. I'm Swedish, so I get them all. And some are not serious, and some are devastating. And the point I want to make, if you get some side effects that are really troubling you, make sure you tell the doctor, because there's remedies to most of those side effects. So emphasize, it really hurts, or I'm really fatigued, and so forth. Emphasize that, because some doctors are so used to hearing about side effects, they just nod their head, yeah, that means the treatment's working. But there's other treatments, and that's what I've run into. So those are the fundamentals. And drum roll, and here's Gene to introduce our speaker and with some other comments. Take it away, Gene.
Okay, let me introduce the doctor here. A little bit about him, a lot about him, as a matter of fact. Dr. Kipper is one of the nation's foremost experts in PET-CT imaging technology for the diagnosis of cancer and brain disorders. He's the author of several medical textbooks and numerous professional journal articles on imaging techniques for the evaluation of cancer and other disease processes. He is board certified by the American Board of Internal Medicine and the American Board of Nuclear Medicine. He is an active member of the Society of Nuclear Medicine, where he sits on the Society's PET Utilization Task Force and PET Center of Excellence website task force. He is also a member of the American Society of Nuclear Cardiology, the Academy of Molecular Imaging, and the American College of Nuclear Physicians. This is a busy man. Dr. Kipper has an academic appointment at UCSD as a clinical professor of radiology. He earned his medical degree from UCLA. Postdoctoral training included internal medicine at UCLA and UCSD, as well as endocrinology and nuclear medicine at UCSD. I'm well acquainted with Dr. Kipper because I was utilizing his expertise, especially in the imaging area, and he was able to locate metastasis in my pelvic area quite some time ago. And then also through those imaging showed I had the small metastasis in the pelvic area. And so I did the Xofigo radium-223 treatment through him. And later imaging showed that that had all been cured, except one tiny spot, which I later had zapped by Dr. Munt, SBRT radiation. So I know him well, and I know he'll bring good information to us. Welcome, Dr. Kipper, again. Thank you.
Good morning. Very nice to see everybody again. I was actually here in 2014, so it's taken 4 years for everyone to forget why I was there and to be asked back to see you. I was interested in the survey that George went through in the beginning, and just to ask my own question, there are physicians here I know, because some of them are friends of mine. There are engineers here that I know, which always make my life difficult because they typically know more than I do. Are there any attorneys here, by show of hands? Okay, well, well, interesting story about, if you haven't heard about the attorney, the physician, and the engineer who were sitting around one night trying to decide which was here first on the earth. And the doctor said, well, he said, of course it would have been a physician because somebody had to take out Adam's rib. And the engineer said, well, I think you have that wrong because in the beginning there was no order in the world. It was random, it was chaos. And somebody had to put things into order so that the world could continue. And the attorney piped up and said, yes, but who do you think caused all the chaos? So, with apologies to my attorney colleagues, we are here to try to clear up a little bit of chaos today. And I look forward to speaking to you about how soon we can find recurrence of prostate cancer and what are some of the basics you might want to know, in part in preparation for the next two sessions you're going to have that I noticed from Dr. Kane and Dr. Rossi, who obviously will be going more into the various forms of treatment, but we'll cover that a little bit as we go along. First of all, let's talk about some of the risk factors for recurrence. We have PSA level, Gleason score, and the stage of one's disease. If the PSA level is equal to or greater than 8, the risk is higher for recurrence. The 6s and 7s not as high. So we look at the original PSA level or the surgical PSA level, which helps us determine the patient's risk. We then look at the Gleason score, and there is no magic number, but typically if the Gleason score is above 15, the risk is higher for there to be some recurrence. And the physician takes that into account as he's talking to the patient to try to get a feel in his brain how much risk there might be for recurrence of the prostate cancer. And then the stage, of course, and I'm not going to go into the great details of what the staging is. You just know that's something we need to do to, again, help us make decisions down the road. Which of the following is true? Look at that and we'll see if you're right or not. First of all, PSA is named after a defunct airline. PSA levels are commonly seen less than 6. PSA means Prostate-Specific Antigen, and all prostate cancers produce PSA. Well, PSA is not named after a defunct airline. PSA levels, whoops, let's go back here. So, All prostate cancers do not produce PSA, interestingly enough. There are certain types that don't. They are the ones that have become what we call neuroendocrine tumors. They're a little tougher to follow, obviously, if they're not producing PSA, and it's a little different animal, but my guess is that almost everybody in the room has the standard adenocarcinoma that does produce PSA. And PSA levels less than 6 really aren't very common. If the PSA level is less than 6, it usually means the pathologist didn't look hard enough to find a higher score to get us to the level of 6 and then above. And so the answer, of course, is that PSA stands for prostate-specific antigen. We talk about, when we're talking about recurrence, biochemical failure or biochemical recurrence, we call it BCR. And we're looking basically at two groups, the patients that have had prostatectomy and then those that have had radiation therapy, because it's a little different for each category. For example, following prostatectomy, if the PSA level doesn't fall to 0, that is called PSA persistence, okay? It just never completely disappeared. Something is still there, something is going on. The second definition is that if it does disappear but then it comes back, that's biochemical recurrence, and we need to see it 2 consecutive measurements. So a lot of times your urologist will not get bent out of shape if one time there's a little blip. That could be a spurious, solid, single-time value. Well, that's interesting. I don't know how that happened, but let's see. Maybe the next slide will fix that. And then following radiation therapy, if the PSA goes up by a value of 2 nanograms per ml, that's an indication of biochemical failure. And if the PSA goes up in a younger person by less than 2, that still would be considered significant. And what do we mean by younger? And that's anybody younger than the physician. I don't know what the stuff is on the side. I don't think it'll get in our way, though, if you can make your mind forget that. Okay, who's a Gleason score named after? Is it named after Donald F. Gleason? Is it named after Patrick Jerome Battleaxe Gleason? Is it named after Jackie Gleason? Or is it named after Vanessa Gleason? Now, hopefully you know who some of these are, and hopefully there's one you don't know, but we'll get to that person. It's actually named after Donald Gleason, who was a pathologist at the VA hospital in Minneapolis some years ago. Patrick Jerome Battleaxe Gleason was actually the mayor in New York of Long Island. Jackie Gleason, I wish it were true, but it isn't Jackie Gleason. He wasn't given the credit for the Gleason score. The one I hope you don't know is Vanessa Gleason, and the reason is she was a Playboy Playmate of the Month. Now, it's okay if you know that. That's fine. I happen not to have known that. Oh, and as President Trump said, did I say I didn't know that? Well, anyway. Jackie Gleason had some contribution to science, though recently on a moon visit, they discovered Alice Cramden on the moon, as this cartoon shows. So what is the role we're going to look at the role of imaging in locating prostate cancer, and we're going to talk about some other things that we use to find recurrence. Imaging is utilized to detect and characterize disease and to aid in treatment planning. The sooner we can find it, the better off we're going to be, and we have lots of different ways of doing imaging, some of which you haven't heard of yet, many others of which you've gone through. We can look at the anatomy in the body, in other words, what does the structure look like, and we can also look at how a structure functions. And those two things together usually give us a wealth of information about determining where the cancer has returned, and then also guide us as to what we need to do next. The efficacy of imaging, it's important, but we have to combine it with the risk factors to try to make the right decision in our patient, because some tests are not indicated at certain times based on the risk. Some are not indicated based on the PSA, and there are other factors that help the physician decide when it's time to image and what to do. The frequency of imaging is an individual factor. There are no absolute guidelines that every 6 months you need a bone scan or every 2 years you need this, that, or the other. It's an individual-based determination. Simplistically, all of our tests that we use have two factors that we look at. One is called how sensitive is the test, and that means if 100 people who have the disease go through a test, how many times do we find it? Obviously, if we could find it in every single individual, the sensitivity of the test is 100%, and that you can't get better than that. Typically in medicine, for all diseases we look at, our sensitivities are in the 60 to 90% range. There's very few tests that are 100% sensitive. The other thing is called specificity, and that means if we find an abnormality in 100 men, how often does that mean prostate cancer? How specific is the test? Because that's important too, because all tests have what we call false positives. And that generates a lot of anxiety, generates additional tests, and frankly, sometimes it generates treatments that aren't indicated. So we want a test that's very high sensitivity and very high specificity. The higher the better for both, and then the two of them combined lead to what we call the accuracy of a test. Okay, and why is early localization important? First of all, is there an identifiable site? Because that determines if our patient is what we call M1 or M0. And you've heard those terms used. It's very simple. M stands for metastasis. If you have an identifiable metastasis, we call you M1. If you don't, it doesn't mean you don't have metastasis. If you're an M0, that's what we call you, but we can't find it. Okay? And those categories often indicate what treatments we recommend for you. There are certain drugs that are approved to be used only in the M1 place and some only for M0. Those lines are beginning to be blurred, which is kind of good news, but we need to know if our patient is M1 or M0. Prior to 2008, we had practically nothing for treating advanced or recurrent prostate cancer. Since 2008, and here's the good news, by my last count, we have 14 new forms of treatment that have come along. That tells us two things. Number one, that's great. And number two, it's even better because you know that there are going to be more coming along at a fairly rapid rate because of the amount of interest, the amount of time, the amount of money being spent to look at men with prostate cancer. The location of the recurrence is very, very important, again, deciding what we use to treat. When prostate cancer returns, 90% of the time it's in bone. 50% of the time it's in lymph nodes. 10% of the time it's in solid organs. So even though the statistics would tell us something, we don't care. Each individual that's the only person we care about. And even though our suspicion that it's come back in the liver, for example, or the lungs, is not going to be borne out by our studies, we still look at each individual and have to consider all of those three possibilities, but normally 90% of the time it's going to come back in bone. Is the site single or is it multiple? If it's single, sometimes some spot welding with radiation is all the patient needs. If it's multiple, the odds are pretty high they're going to need systemic therapy with some of the things that were mentioned just before I got up here, with some of the newer agents that we have that will treat the whole body, not just one single site. Are there additional studies that are necessary after we do our initial evaluation? Much of the time there are additional studies that need to be done to add typically specificity to our test, to be sure that what we're looking at is actually a recurrence. Is tissue sampling a consideration? Sometimes it is. We don't want to radiate something that isn't prostate cancer, and if our tests don't tell us for sure, we can go ahead and take tissue sampling because, as you know, prostate cancer typically is a disease in men after 50, although we're seeing guys in their 30s. And the older we get, the more likely we are to have tumors of other types. So you can have a tumor of another type, and we don't want to make the assumption that everything that glows on our scan is prostate cancer if it doesn't fit the typical pattern, and sometimes we have to get tissue. And sometimes, frankly, as some of you know, we have to go back in and rebiopsy the prostate bed area. So that tissue sampling arm of this latter is an important one. And there are recognized cutoff points as far as our ability to cure the cancer or to keep it under good control, based in part on the test that we have and on the PSA. That should disappear in a second. For example, the radiation oncologists like to radiate, if they're going in for what we call salvage radiation, before the PSA gets above 1, certainly before it gets above 2, because our patient stays in what we call the cure bucket, and we can take care of it, get rid of it, if we get it with a PSA early enough. Okay, so what are our diagnostic tools? What's available to us? Okay, we're going to talk about imaging, but we're going to talk about other things briefly to give you an overview. First of all, there are the patient's signs and symptoms. Signs are what we can actually put our hands around, we can see them, they can be documented, they can be quantitated. Symptoms are what the patient tells you. I've been nauseated, I've got burning when I urinate, those are symptoms. Signs, he's got a big mass on his chest or whatever it might be. So signs and symptoms are helpful. Blood tests can be helpful. Plain radiographs, just x-rays, can be helpful, although they're not used as much anymore because they're not very sensitive. CT scans, one of the mainstays for a long time for us to look at the organs throughout the body. Magnetic resonance imaging becoming more and more important as each year goes by. It's a test that allows us to look at anatomy and function now with the way they do MRIs. Nuclear tests like the bone scan, the PET-CT studies that we can do, and we'll cover those. And just 10 seconds about DEXAs, we use that in evaluating our patient for bone loss. So those are the diagnostic tests that we have available to us. Let's first talk about patient signs and symptoms. What about local recurrence? If recurrence is local, although these are not hard and fast immutable rules, the patient may have burning or pain during urination, and I know you're all thinking about yourselves now, and that's okay. Difficulty urinating, trouble starting and stopping while urinating, frequent urges to urinate at night, loss of bladder control, decreased flow or velocity of the urine stream, and right now you're thinking, how did this guy get my history, right? I mean, let's face it, they're very common symptoms that don't have to mean cancer, but these are the common symptoms we see if it's local recurrence. And then finally, if you have blood in the urine, that's more likely a local recurrence than a distant recurrence. Now, what about if it's metastatic? What if it's spread out throughout the body? Are the signs and symptoms different? Well, they are. You can have erectile dysfunction. You can have swelling in your legs or pelvic area due to blockage of the lymph nodes in the pelvis. You can have numbness or pain in the hips, legs, and feet, which may be due to some compression on the spinal cord from bone metastases. And bone pain that doesn't go away or results in fractures, that can be a sign that you're in that 90% where it has recurred in the bone. Blood tests. All right, what do we use? What are the ones available to us? We could look at the PSA value. We can look at what we call the PSA doubling time, and that is how long does it take your PSA value to go from one number to twice that number. That's called the doubling time. The shorter that time is, typically the more aggressive the tumor. The longer your doubling time, the better. So if you have a PSA of 2 and it takes you 6 years to get it to 4, that's low risk. That's not a problem. It's a long doubling time. On the other hand, if you have a PSA of 5 and 2 months later it's 10, you've got a short doubling time, and that means it's a more aggressive tumor. You can actually go on the internet, and Memorial Sloan Kettering has a nice calculator that you can use by plugging in your PSA values and find out what the doubling time is. But your doctor can tell you that. Testosterone. Alkaline phosphatase is a measure of it's an enzyme that's found in bone, liver, and in the intestine. It's typically bone, and if that number goes up, that tells us something's going on in the bone. Doesn't tell us what or where, but with prostate cancer, you have to be concerned it might be in the bone. So we measure that each time on our patients. A blood count is sometimes necessary to make sure that the prostate cancer has not invaded the bone marrow to the point where you're not producing red cells, white cells, and platelets. Liver function tests are important because some of our drugs have side effects that affect the liver. Some of you may be on abiraterone or Zytiga, so we like to measure the liver function studies. And then sometimes we need the kidney functions because if we're doing certain types of x-rays which require the administration of a contrast agent, whether CT or MRI, we need to know what the patient's kidney function is so that we know they can tolerate that dye, if you will. PSA, the prostatic-specific antigen, is produced in the prostate, and it's mostly found in the semen. It is an enzyme which liquefies the semen so that the sperm are free to swim and dissolve the cervical mucus. And when we take out the prostate or radiate the prostate, if you think about it, you shouldn't be able to produce any more PSA unless something is going on somewhere. You've heard the concept of the free PSA and the bound PSA. I'm not going to say any more about that, except the higher the free PSA, the better it is. That's for the guys that are on active surveillance and or have not yet been diagnosed, have just had a little bit of an elevation of the PSA. Testosterone facts, these are important for you to take home. They'll be on the quiz afterwards, so you might want to jot these down or wake up the person next to you who might help you remember them. In men, testosterone is produced by the testes and the adrenal glands. It comes from those two places. It is also produced by prostate cancer cells themselves. Okay, so even though you're going on androgen deprivation therapy, its major effect is on the testosterone produced by the testes. They may not affect the production from the adrenal gland, and they may or may not have a complete effect on the testosterone that's coming from the cancer cells. And the body's remarkable. It can take the smallest amount of testosterone that's produced and become responsive to it. And that's why you can have very low testosterone levels, but it might be enough to stimulate certain cells to make PSA. So the body somehow, some way, not in a good way, adapts and can still make PSA with very low testosterone levels. Production actually begins in the 8th week in utero. So our testosterone, the men that are here, we're making some by the end of the 2nd month of gestation. And there is something called an equivalent in men to menopause in women. It's called the andropause or male menopause or the viropause, but there is that entity, and it does happen as we get older. The testosterone level does fall. It's interesting that women have levels of testosterone as well, and these can change in response to what's going on in their body as well. Testosterone 2 facts, prior to competition, whatever the competition might be, whether it's a football game, a game of cards, mind game, whatever it is, testosterone level in men will go up, okay? If the player or his fans' team wins a game, the testosterone level goes up. It's a fascinating hormone, okay? It's the aggression hormone. All right, here's what everyone wants. The second thing you take away with you, if you take a look at your right hand, and you look at it from the back, doesn't matter. In men, the pointer finger on the right hand, the index finger, is going to be shorter than the 4th finger on your hand. Okay, that's a sign that you've been exposed to testosterone in utero. And in women, it's just the opposite, that the pointer finger is going to be longer than the 4th finger. And I always like to do this because I want to see how many guys start to sweat when they have fingers that look like women's fingers. So you can look at your fingers in private and then do with that information what you will. The very first X-ray was discovered in 1895 by Wilhelm Röntgen, okay? And this is a picture of his very first X-ray. I don't know if any of you have ever seen that, but this is his wife's hand, and that's her wedding ring, and that's the very first X-ray that was ever taken. Then came bone scans in 1970, CT scans in 72, MRIs in 77, and then PET CT scans in 2000. So all these things are relatively recent if you look at it compared to how long man's been on the earth. Now, in medical history, it's not that long, but things are fairly recent there. Plain radiographs, just like Röntgen developed, they can be used, but there's a problem with them. You need to get rid of about 50% of bone before an X-ray is going to show an abnormality. and that takes a long time. So they're not particularly good finding things early on. But if they do show something, they're very nice to add specificity to another test. Plain radiographs really don't have much of a place in looking for the recurrence of prostate cancer. Okay, they really don't. Let's look at bone now, because then came bone scans in 1970s. We do whole body bone scans. Currently, a bone scan refers to the nuclear medicine scan, where you get an injection, you come back 3 hours later. They start at the top of your head, they go to the bottom of your feet, and they have a beautiful view of the skeleton. Bone scan is very, very good at finding metastatic disease. If they can't be sure, sometimes they'll ask to get an MRI of an area of abnormality, sometimes a CT, so they're not very specific. If you look at somebody cockeyed, they probably get an abnormality on their bone scan. So very sensitive, okay? Nearly 100%, but not very specific. There's what a whole body bone scan technology, which is a new technology, is called sodium fluoride. How many by hand have had sodium fluoride? Ne'er again. The CMS has decided twice now that they will not cover sodium fluoride. It's a better test, it's more sensitive, it's more specific, it's more accurate. It's got a CT component so we can look at other things on the scan, but they said we're not going to pay for it because we don't have enough evidence that it saves lives. And that's all CMS cares about. Okay, they don't care if the quality of your life is improved. They're not going to approve anything. They have to show a survival benefit for the study. Now, you can still get it. Selected patients can get it. Read that as if you can afford it. The timing of bone scanning is dependent on many, many factors. You know, how long it's been since the patient has had his primary treatment. Is the patient symptomatic? A whole host of factors. Leave it up to your doctor. He or she will know if timing is right for you to have a bone scan. The good news is the radiation exposure from a bone scan is minimal. There are no side effects from it. It has no effect on the kidneys. No dye is used. And so it can be done very frequently without any risk to the patient. So it's a good test. The standard bone scan is probably not going to be positive if your PSA is less than 10, and especially if you don't have symptoms. So the thought about jumping in and getting a bone scan immediately when the PSA goes up to 2 or 3 or 4 or 5 may not be in the cards if you're not having symptoms. There are some pitfalls. One of them is called the flare phenomenon, and that is when you start treatment, or change treatment for your prostate cancer, it may be successful, but it can cause a temporary inflammation in the metastases from the treatment itself, and the bone scan will show more spots than it showed before you started treatment. That doesn't mean you're worse. It just means that you flared. And actually there are studies that show that those men that flare do better than those that don't. So your doctor kind of has to know how to look at those scans to determine if really things are worsening or you're actually just getting better from your treatment. So that's why my recommendation typically is let's wait a little while to get a repeat study, because the flare phenomenon can last 2 or 3 months. On your left is a normal bone scan, and that's what a skeleton looks like. On your right is a negative bone scan, but what we do look for is we look for areas of, that's the one that didn't work. Don't worry. We look for areas of dark spots, and you say to yourself, oh, well, hey, Dr. Mike, there's dark spots all over the place. That's because this is an adolescence bone scan, and all those little linear areas that you see of uptake are normal, what we call growth plates. The bone is still growing, and those will show up on a scan. But typically we don't see those, and we look for a dark black spot somewhere in the bone scan where it doesn't belong. This is a patient with a very low PSA, and you can look around, and this is kind of where everything belongs in him. We don't see any black spots except the one in the pelvis there, and that's the radioactive urine that's made its way into the bladder, and that's not going to get in our way. And you can see on the scan on your right, we're looking at the person from behind. You can see a couple little kidney bean shaped places there. That's the bladder. These are the little kidneys, okay? And that's what a pretty unremarkable bone scan looks like. However, 6 weeks later, that same patient went and had the sodium fluoride, the one that we can't do. And here you can see a bunch of little teeny spots throughout the spine. This is the 5th lumbar vertebra, and there's a big bright spot right in there. Here it is on the CT component of the scan. Here it is on the nuclear. So the sodium fluoride was definitely positive, completely different than the regular bone scan. One of the reasons I liked to do sodium fluorides and did thousands of them, but CMS put the clamps on it. And also because sodium fluoride gives us a little bit of it gives us a CT scan superimposed on a bone scan, we can get precise localization of where the abnormality is. We're not that good with a regular bone scan. Just like these mice are now figuring out where they are in the snake, we can figure out where that abnormality is. Here's a bone scan in a patient whose PSA was 0.2, and it's a sodium fluoride. And here's one of the vertebrae. And here it is, very nice and easy to see with the sodium fluoride. Never saw it on the regular scan. This is what we call a super scan. Don't get nervous, just take a deep breath. You can have a lot of metastases in the bone. It doesn't mean we can't treat them, and most of the time the patient's not having any symptoms, but sometimes they can look like this. And every one of those sites is a site of metastasis. Now, one of the things that Gene mentioned is one of the treatments when it's in bone is something called radium. I talked about that 4 years ago, or Xofigo. And we use it in men who have bone-only disease. So we got to prove that it's just in the bone. So this is a patient who came to me, looked like a perfect candidate for radium. As far as we knew, he had only disease in the bone. His PSA was going up in spite of being on everything we could throw at him. And we thought we need to use Xofigo, our radium treatment where we inject and it goes to the bone. And you look and you can see all these lesions throughout the spine, up in the shoulders, here, just lots of them. So he kind of looks like a good candidate because the bone scan's positive. We needed proof there. But unfortunately, when you look up in his chest at the CT component of our scan, what you see is that this little area in the lung, which is a metastasis, which is not in bone, that makes him a non-candidate. So rather than put a guy through 6 months of something that's not going to do the job at a great expense and at some risk, we now, because it was a sodium fluoride, can say, sorry, that's not the right choice, and we had to move on to something alternatively. There it is. Now this is a patient with a normal technetium scan. But when we did a sodium fluoride, what you can see are all these white spots in the spine here, and this turned out to be, and again, another example, but we also got the CT part of it. So we got to look at his liver, and look at the liver's got metastases in it. So there are, at least were in my opinion, some real advantages to sodium fluoride, but again, we do what we can do, and now we're back to just doing the regular bone scan, which is still a good test. It's an excellent test, and I'm guessing that every one of you here has had at least one, and most of us are going to have more throughout the course of our lifetime. Now, CT provides excellent anatomic detail. It's really nice detail of all the organs and the bones, and it can find disease in the lymph nodes, it can find it in organs, and it can find it in bone. Let's see, here we go. You see incredible detail in the bones with CT that you actually don't see with a regular bone scan. This is an 850-year-old mummy that was discovered in a trunk in a garage in El Cajon. And when they found that mummy, they said, well, let's see what else we can figure out about this mummy. So they said, well, here's what we do. We do CT scans on these kinds, in this situation. And we can, kind of get an idea of the age, and we can kind of get an idea about what the bones were like, kind of tell us how old that mummy was. Well, they could tell something else if you're paying attention. You could see that she turned out to be in her 20s. Well, why do we say she was in her 20s? Because we can't know. There's no soft tissue organs we're going to see. Well, if you're careful and you look, there's a little skeleton down here in the pelvis. There are some ribs down there. She was pregnant. So this 850-year-old mummy was in her 20s, a female, and pregnant. And that's a true story and took place in El Cajon a few years ago. Here's an example of what a CT can show us. This is a CT from one patient. This is the bladder filled with urine. This is the pelvis posteriorly. There's a big grouping of lymph nodes back here that shouldn't be here. You don't see it on the other side. There are lymph node metastases. This is the iliac bone on the left. You see this bright spot in here. There are bone metastases in this patient. And this is the liver, where all these dark spots are metastases. So again, lymph nodes, bone, liver, could look at all of them with CT, an excellent test. That's why when there's might be a recurrence based on the PSA value, we will often send the patient for CT scans and a bone scan. That combination should typically tell us all that we need to know. Magnetic resonance imaging, great soft tissue characterization. There's no ionizing radiation when we do MRI. You can do it with or without contrast, most of the time with contrast. The contrast is much more gentle than it is with a CT scan, but theoretically there can be some effects on the kidneys. They do now something called multiparametric MRI, which gives us not only anatomical information, but functional information. It's a very, very good study. We're also using it, mentioned earlier, in conjunction with the ultrasound to direct our biopsy. It's MRI-guided biopsy of the prostate. It's especially good at finding areas of high-risk, aggressive cancer. Okay, it's much better at finding the higher Gleason score lesions than the lower Gleason score lesions. And it's good risk stratification in men who are considering active surveillance. Not a bad idea to have an MRI to be sure that active surveillance is the right course of action. Because if you see a lot of lymph nodes around the prostate area that are involved with cancer, you got to rethink it as to whether active surveillance is the right thing to do for you. Or you see some really, a real high risk area, you may need to rethink it. It's a very good correlative study when the PET scan or the bone scan or whatever it might be isn't convincing. You add an MRI of that local area and you can usually make your diagnosis. Just an example of what we mean by an MRI. This here is the prostate area. It should look white just like this, but here on the right side it's black. That's an area of cancer. Real nice images. And here's what bone mets look like on an MRI. Real easy to see. It's a good study for looking at bone. PET-CT is what I do for a living. I'm not talking about the standard PET scans for other types of cancer, which I'm sure a number of folks in the room have had. The standard PET scans use something called fluorodeoxyglucose, which is an analog of glucose, which is a sugar, and most tumors take up sugar more than surrounding normal tissue, so we look for hot spots or dark spots on a standard PET scan due to the body's utilization of the sugar analog. But prostate cancers aren't like that. They don't care for sugar. They're too slow growing. But we do have a place for PET-CT with prostate cancer, which I'll get into in a minute. If someone has a really, really aggressive prostate cancer that's growing quickly, that tumor may well show up with a standard PET scan, but we don't use them that often any longer. So the new agent we have is something called fluciclovine, which is a synthetic amino acid, and we know that prostate cancer uses amino acids to a greater extent than do normal cells. So you make your injection, you wait 3 minutes, you take your pictures from the head to the knees, and you'll see little spots pop up that show us where the prostate cancer is. Fantastic way of finding recurrence. We can find it all the way down to PSA levels that are between 0.7 and above. It is covered by CMS. There are no risks to the study. Well, it's also using fluorine, so the half-life is 2 hours. It's the same agent that we use with FDG for regular PET scans, so it's there for 2 hours. We told you that. Recurrent prostate cancer can be found in lymph nodes, organs, or bone. It doesn't matter with Axumin. It'll find it in any place. It's been approved for the indication of finding recurrent prostate cancer. And oftentimes the patient will undergo a bone scan and a CT scan first, still not find it. And we want to cure this patient. We want to find it as soon as we can. These are the guys that are being sent over for the Axumin studies, because if we can find it, we can still cure the patient rather than just use our treatments to, add years and years of life, but we'd rather get rid of the cancer altogether. It also, if we find around the prostate area, in the pelvic area, there are some lymph nodes that are positive, the radiation oncologist, when he or she goes in to radiate the prostate bed, if that's what they're going to do, can just extend the field of radiation a little bit and get those lymph nodes and still get rid of everything. So it changes what the radiation oncologist does. What also changes what the radiation oncologist does is if we find a site in a lymph node in the abdomen, but we don't see anything in the prostate area, they don't have to radiate down there. That's not going to do the patient any good. So they just go up and they zap up above where that lymph node is, and then we just follow with PSAs, and we can cure those patients. We can treat the actual spot where it lives rather than just randomly radiating the prostate bed. The positivity with Axumin is related to the PSA and the doubling time. For extraprostatic, meaning outside the prostate disease, the specificity of this test is 95%. That means if I tell you there's a spot in your right lower lobe of your lung, 95% of the time I'm going to be right. There's very few false positives around the body, and that's very helpful because the radiation oncologists know this, and they're very happy to go ahead and radiate that area just because it's so accurate as far as specificity is concerned. Just show you some examples of the Axumin, and we've been blessed, or I've been blessed. We've had more experience here in San Diego probably than anybody in the country, and at this point in time, if there is a patient that's done anywhere in the country where there is some question about what their Axumin study shows, they send them to me to read, to look at. So we've got local expertise for you in a study it's quite good. And as Gene and George know, there are other nuclear studies that have come along that are also of value, and I'll just mention them as we finish, and we're coming near the finish here. This is a recurrence in a patient with a very low PSA, tiny little area. This is the bottom of the prostate gland, this tiny little yellow area, probably just a few millimeters in size. That's a recurrence. This is a recurrence in the right side of the prostate gland. Okay, you can see it here with the arrow pointing to the yellow area. So now we know, since there was nothing else on this patient, that the radiation oncologist could go in and radiate the prostate. Salvage radiation should be a cure. This is the liver, this is the pancreas. Those two organs take up this Axumin in great amounts because they're very rich in amino acids and very active in amino acid metabolism. So if we don't see the liver and the pancreas, something's gone wrong with the way the test was performed. These are 2 sub-centimeter sized lymph nodes in the pelvis, yellow here, black on this view. They're there on the CT, very small. They would not have been called abnormal on the CT scan because they were too small. And CT just uses the size of a lesion to say whether it's abnormal or not. But if you add the Axumin and the Axumin lights it up, those are metastases, those you need to go after. So this patient had radiation of those two nodes. This is what a metastasis in bone looks like. I used a different color table to make it more obvious to see them. Here it is here on just the PET study. So we find a couple in the bone, and that changes then how we treat the patient, okay? Sometimes the radiation oncologist will use CyberKnife 2, 3, 4, 5, 9 spots, so they might be willing to do it there. But if we find a lot all over the place, we're going to go to systemic treatment. This is a metastasis in the sacrum. Here's the whole body. It's as if you're looking at me with my back to you. This is the patient's sacral area. And this little yellow spot, tiny, tiny spot, was the only spot the patient had. So they go ahead and they radiate that. This is the only spot in this patient whose PSA was very low. And it's in the 11th thoracic vertebra. On the CT, you can see that little whiteness there. Is it arthritis? Is it trauma? Is it real? Is it Memorex? It's real. It's got some uptake on the Axumin study. That was radiated. This lymph node was 9 millimeters in size. Okay, lights up no problem. You can see it being pointed to here on the CT. CT uses 1 centimeter as the cutoff in the abdomen and pelvis, 1.5 centimeters for the cutoff in the chest before they're going to call it abnormal. This would have just been said, well, there's a 9 millimeter lymph node. Don't know what it means. When you do Axumin, you know what it means. These are nodes up by where the aorta and the vena cava come together. There are a couple of them in here. You can see radiation is the treatment. Single lymph node in the symphysis pubis. It says right, it should be left. Did I say right? I meant left, actually. So, and I did actually mean left. This is the bladder. This is the cancer that's made its way into the posterior aspect of the bladder that we see here with the Axumin. The seminal vesicles are removed during a radical prostatectomy. They're taken, they're gone. We want to know typically if the seminal vesicles are involved because that's a risk factor. Some surgeries do not remove the seminal vesicles. Okay, some of you may have had surgeries where they left the seminal vesicles in. We don't really need them, but they were left in there. But this is a patient where the seminal vesicles were not removed at surgery, and here is his left seminal vesicle. No difficulty seeing this. This again, invasion into the bladder. You are now able to read these as well as I can. So just a couple of you leave your phone numbers for me. This is multiple nodes throughout the body and in the prostate area. So it doesn't matter if there are 14 spots. We're going to see 14 spots. It's not a matter of it being sucked up by the bigger spots and the little ones don't show up. They'll show up. And then there's some unexpected findings, like what Kermit found out what was inside of him. And part of the unexpected findings are because, again, an Axumin study, because it's PET CT, is a CT study, and the PET study superimposed. So we get anatomy and we get function. We can precisely locate it, and we can look everywhere. This one I saw not too long ago. This is someone who they thought, who sent to me from Missouri to look at the patient's scan, because they said, Mikey, he's got this thing in the brain, so he's got a metastasis in his brain, right? The answer is wrong. First of all, prostate cancer does not typically go to the brain, and there would be other signs that it went to the brain. And secondly, there have been 2 reported cases where Axumin has gone into benign meningioma, which is a tumor of the lining between the skull and the brain. And indeed, he had a history of multiple meningiomas, not all of which had been removed. So he sent back and said, no, this is a meningioma, leave him alone. The rest of his study's negative. So that's what a meningioma can look like. But you can see why you get nervous. I mean, it's clearly there, and it's clearly taken up the agent we use to find prostate cancer. The first Axumin study was actually done in someone where they were looking for renal cancer, and they didn't see anything in the kidney, but some lymph node lit up like crazy. So I said, his kidney cancer has gone to the lymph node, because they thought it worked in kidney cancer. They weren't sure. So they biopsied it, and it was prostate. And they said, wait a minute. We have something we might be able to look at for prostate now. So serendipitously, they started studies, and sure enough, it works very well for prostate. What about a spinal canal metastasis set for a second read, second opinion on a gentleman who had a number of sites in his bone, and they just said, just confirm that they're in the bone. So looked at the study, and if you take a look right here, that's the spinal canal. That's where the spinal cord lives. And if you look even more closely, what you can see is that this pointer is no longer working, but the bone on just to the left of that focus is not as nice as the bone on the other side. So there was tumor that had eaten through the bone and gone into the spinal cord. Is that important? Yeah, if you don't want to be a paraplegic, it's important, because if you get it in the spinal cord, it can transect, it can cut it across, and everything below the level of where that is no longer functions. Bowels, bladder, legs, whatever. So we had this gentleman sent immediately for an MRI, which confirmed what we saw, and immediately to radiation to prevent him from becoming a paraplegic. So it's an incidental finding which made a difference. What about a destructive mass? Look at this mass of prostate cancer that has eaten away the iliac bone on the right side. Okay? So yeah, we found a site of metastasis, but that thing has to be addressed now. Okay? So that's what the soft tissue part of the scan that we got helped us determine. Just about done. Pelvic met, they wondered about. Yeah, there's a met in the pelvis. Here it is. They're correct. They didn't see that the other side was fractured. Okay, so tumor had gotten in there and fractured the other side. Incidental finding, but important. Probably an explanation why the guy kept saying, I'm having pain over here. What are you guys going to do for this pain? And they said, well, no, you only have a met on the other side. So. Congestive heart failure. Well, you can see the metastasis here, but all this stuff is fluid in the lungs. Okay, so we diagnosed congestive heart failure based on an Axiom study looking for prostate cancer. One word about DEXA, we use it to check bone health. It doesn't have anything basically to do with recurrence, but treating bone health is important to us. And now we go to our summary slides, and that is the development of new therapies for recurrent prostate cancer is a large part of the impetus for us to try to get better with our methods, because the sooner we find it, the sooner we can treat it, the better the outcome. Along those lines, Axiom is not the end of the story about the nuclear studies. Some of you have heard about gallium-68 PMSA. Some of you have heard about C11 acetate, which Dr. Almeida does in Arizona. Those are excellent tests as well. The reason I'm not dwelling on them is because first of all, PMSA gallium-68 is not approved yet. Carbon-11 is hard to get. You have to go there. You have to pay for it. It's about the same accuracy as Axiom. The head-to-head studies show that Axiom's a little better, but that's not important. So we've got even a couple more beside the Axiom that work just like the Axiom that can help us find it. And the other thing we have now with the gallium-68 is if you can show that it's positive with that nuclear scan, you can then refer the patient for treatment with something that is a new and a good treatment for it. It's called lutetium. While imaging remains an important part of this effort, accurate risk factor analysis is also very, very important, as is probably the role of genetics, which we're just scratching the surface on. Immune therapy, you've heard of Provenge, there are others that we have. And personalized therapeutics or personalized medicine, which helps us individualize treatment for everybody, are continuing to evolve. The currently available methods to identify subcentimeter sites of disease include CT, MR, PET-CT. We can find disease when PSA values are less than 0.1 with some of these tests. So that we can deliver precise treatment to the site of disease and keep the person in the cure bucket where we want them to be. What we don't know, however, at this point in time, is that as good as these tests might be, and as early as we can find them and then treat them, does that change the overall outcome in that individual patient? In our heart and in our brain, we want it to change it. We don't have that data yet. So that's being looked at. And that's part of the reason that some of these newer methods have not yet gained approval, is they've not been demonstrated to show a prolongation in survival. We're hoping to have that proof as things go forward. And that's it. So I appreciate your time, your attention. And George, I think you were going to kind of moderate any questions.
That's the fat lady who's singing.
That's right.
Okay. All right, let's open it up to questions. And what we'll do, we'll start over here and then go down there, and then we'll come back here. So you're the first one.
This is a good place to sit. Okay. So I have a question about, in the bone, faster growing cancer or slower growing? Sclerotic lesions. How do you, if a cancer's not growing that fast, or it was growing and it stopped, how do you deal with that?
Yeah, that's a complex and great question. They're basically two, and I hope I get to the answer.
Could you repeat the question?
And I'm going to repeat the question, and that is, cancers can grow in the bone at different rates. They can be slow growing, they can be fast growing. Can we tell the difference? Does it make a difference? How do we handle it? There are basically two types of metastases in bone. One is called osteoblastic, where it shows up as a bright spot on the scan. The other is called osteolytic, where it's a eating away process, where it might not show up well on most scans. The ones that are the osteolytic are the faster growing ones. Most cancers in prostate are the blastic ones, a little slower growing, 90 to 95% are osteoblastic. The way we tell the difference is based on the scan we do. The Axumin can find both, no problem. Sodium fluoride will find both, no problem. The standard bone scan will only find the osteoblastic ones. It finds the slower growing ones. Whether they're slow growing or fast growing, thankfully, we can typically determine from the rise of the PSA and the alkaline phosphatase level. Those are important indicators for us. I had one other thing I was going to mention. Do we treat them differently? Typically not. The other thing I was going to mention to you, and you should all know this, is for those of you who have had bone scans, I'm going to guess a significant percentage of you have had some positive findings. They've shown something in the bone that may indicate metastases. Once your bone scan is positive, it will most of the time always stay positive, whether there's an active tumor there or not. And it's because the body is continuing to repair that area of damage from the tumor. And once it starts repairing itself, it will do that for life. So it's not uncommon for us to see a bone scan that stays the same. We look for two things. Is the scan showing more lesions or lesions in different sites? That means there's been progression, faster growing. Is the scan the same, or are you one of those fortunate people who, where they're disappearing, which is not that common, we know things are stable or getting better. So we have to use all those factors together in looking at the bone scan to help us determine fast growing versus slow growing, blastic versus lytic, stable versus progressive, single versus multiple. And I hope I answered it. It's just a question that it took me literally 7 years to figure a lot of that stuff out.
Okay, question there.
So your cancer is fast growing, and you're on hormone therapy, and that brings your PSA down. And you say to your doctor, is there a point when I can have a scan to find out how bad I am? So you're on this hormone therapy, so your PSA rises and it comes back down. Wouldn't it be good to have a scan when your PSA is like rocketing up right at the peak? Because I'm going from 2 to 10 in a matter of 3 months.
Yeah. The question is, is it a good time to have a scan if your PSA shows a short doubling time and you're wondering what's going on inside of me? And the answer to that is yes. When you have a doubling time of less than 8 months, or you develop symptoms, we feel a scan is in order. Is the scan a bone scan, or is the scan an Acumen scan, or is the scan some type of focus scan like a CT or MRI? If it is a rocket rise like that in a short period of time, it typically makes the most sense to start right then with a bone scan, because statistically that's where we're going to find something. If the bone scan is negative, but you have a pattern of having gone from 2 to 10 in 3 months, that's a patient who should go have an Acumen study, which will let us look at the rest of the body at a PSA level where the Acumen study is near 100% accurate.
Do it at 10 or do it at 2?
Well, again, it depends on how long it took you to get to 2 from wherever you were. If it took you 2 years to go from 0.1 to 2, you might want to wait a little while to get more accurate as far as the bones, if you're not having symptoms. If you're having symptoms, do it right then at 2 with a bone scan. If you're not having symptoms, you can wait a little while to see that PSA go up a little bit higher, but a level of 2, Acumen works beautifully, and if you're nervous and you want to know at that point, your doctor should consider an Acumen study, because again, the accuracy is going to be close to 100%.
Okay, in the back.
Doc, I thought you said in your presentation that it might be detrimental. As a result of a lot of prednisone for a different disease, the neurologists want to do a bone test to see how my bone density is. I'm in remission right now after chemotherapy, radiation, and the hormone treatment. Should I be concerned that I'm going to go in and activate something by doing a bone test like that?
That you might cause something to happen from the bone test?
Cause something negative. Everything seems to be quiet right now.
Oh.
And I thought you said one of the potential side effects of...
Oh, no. The question is there a risk at doing a bone scan because you might cause something to happen? What you're referring back to is what I call the flare. And the flare is only a scan indication that something's happened to the metastases. It does not activate prostate cancer. No chance.
Thank you.
Okay, one for this.
I had my surgery and had my prostate removed in 2004, and they did PSA tests for about 5 years and said, "You're good." Does that mean that it is good, or is it now that there's better tests? And, I mean, they just kind of left it at that.
The question was if prostate surgery was done 14 years ago and for the first 5 years after surgery, everything was fine. The doctor says everything is good, not to worry. I think it's best if you think about prostate cancer as a disease for life. It doesn't mean that it is, but often enough it'll come back many years later based on its growth rate that it should never be completely forgotten, and even 5 years later a periodic PSA is indicated. Unless, of course, you have symptoms and you want to get there right away. Because prostate cancer can be very, very slow growing, but unfortunately 9 years later, 13 years later, it can come back. So you don't want to stop having periodic PSA values, especially since we have such good treatments now which can continue to make you a cure if something is found when you've got a slight PSA rise, where you can find the single spot that's causing it and then radiate it.
Okay, question.
How small a tumor can the Acumen find in terms of millimeter and PSA, and what would the corresponding numbers be for the sodium chloride test?
The question is how small a tumor and how active or inactive based on the PSA does Acumen need to be able to find it versus how soon can we find it with sodium fluoride. The Acumen study, I have one example where we found a tumor that was 3 millimeters in size that lit up on our Acumen that was proven to be a metastasis. That's the smallest I've gone down to personally, is 3 millimeters. The PSAs, we have found tumors with Acumen as low as PSA values of 0.2, okay? Not 1, not 2, but 0.2. Gallium-68 has gone down even lower than that in some of the things it has found. But the sensitivity of the Acumen test below a level of 0.5 is really only about 30%. So it's not great, but it can still find it once in a while. Sodium fluoride does not depend at all on the PSA level, except that positive bone scans are more common the higher the PSA is, and there is no size limitation with sodium fluoride. It could be just a couple of millimeters, 3 millimeters, if it's tickling the bone, and then we can find it. So those two tests are very sensitive, and they're both very specific, certainly at levels above 1.0 for both studies.
Yes.
Yeah, if I switch the doctors to Dr. Dato at Genesis Healthcare, would you be the guy to read the bone scan?
Yes, typically if we have patients to go out for studies, Dr. Dato and I are the ones that work in the Prostate Cancer Center. We will request the scan so I can actually look at all of them and then report back to Dr. Dato.
Okay, in the back.
It sounds like, okay, after you've undergone a treatment plan, let's say like external beam radiation for a period of 8 weeks, then it's going to be, you're going to be, the follow-up to that would be typically monitoring your PSA at some intervals of time.
Yeah, is that the, I didn't mean to be nodding, is that the whole question?
Okay, so it's kind of a complicated question.
Okay.
It's two-part because, okay, so you have been dealing with a urologist and you made a decision to go for radiation.
Radiation,
So
had your
with a
radiation.
oncologist. Who's got the lead there? Because it seems to me like the urologist is monitoring, or I go back to that, for the ADT. And now you're kind of handed over to the radiation oncologist who's going to be doing the radiation treatment. And so it's kind of a vague line on who's on first, you know, between the urologist and the radiation oncologist.
Okay, I think it's actually a fairly simple and a good question. That is, you've had radiation therapy as your primary pharmacotherapy for your prostate cancer. The question is, what's next? Okay, the radiation oncologist typically will see you for a period of just a few months to make sure that didn't have side effects, or if they were, did you get minor side effects, have they disappeared, and then be available to you in the future if needed. Your care then should go back to the urologist, because typically anything else that you may need is going to be within his or her purview, whether that be ADT, whether that be secondary treatments with the enzalutamide, the abiraterone, the apalutamide, Provenge, Xofigo, whatever it might be. The urologist will know if you are in a situation where your best form of additional treatment, if necessary, is with the radiation oncologist, and will then send you back to the radiation oncologist. So the urologist will be your best quarterback.
Okay.
Okay, question here.
Just a memory test for you. In 2017, I had an Acumen scan at IHS through Genesis, and you did a second reading of that scan, which you may not remember, and that scan was negative. But I have other scans that show cancer in the lungs and the lymph nodes. I wondered if you could comment. I'm not the only person who's had a negative Acumen scan, so it certainly wouldn't work for me for some people, but it didn't work for me with this other guy, and so I wonder, who's your opinion on why this happens and can you do it?
Okay, the question is, are there reasons that Acumen could be falsely negative? So the first question to you is, did what you turn out to have within the lungs and the lymph nodes, was that prostate?
Too risky to biopsy, so who knows?
Okay.
My present PSA is 40.
Okay, so the odds are reasonably good with a PSA of 42 that it's prostate. We don't know that for a fact. And do you recall what the PSA level was at the time IHS did your Axumin study?
I think it was somewhere between 15 and...
And was the study read as negative by IHS and after I looked at it as well?
Yes, sir.
Okay. There are rare cases of negativity, false negatives with Axumin. They are very, very rare when you get to PSA levels of where you are. One of the possibilities is that the cell nature has changed from the typical adenocarcinoma to more of what we call a neuroendocrine type of cell, which has a higher propensity to spread to organs like lung, which you mentioned that you had. So it's possible the nature of the cells has changed from the typical to the atypical neuroendocrine cell type. You do not qualify for a false negative based on your PSA value. It was high enough, not a problem there. The other reason and I've seen this, that Axumin can be negative is that Axumin does not work for most tumors, okay? It just doesn't work. So it's conceivable there's a different tumor taking place in some patients that we see. Doesn't sound like the case with you because the PSA is up at 42. So I'm not going to use that as an explanation. The only thing I can come up with is that the nature of the cell has changed so that it is not relying on an enhanced amino acid activity level.
An additional fact is that I had a sclerotic lesion in T11, measured 1.2 centimeters, and that had been growing since 2014, and it did not pick up tracer on the carbon 11 choline or on the Axumin, but it did on the gallium scan, and so did the lung.
Yeah, and that's why we have 3 instead of the 1 perfect agent, is none of them are 100% both ways. We do have an occasional false negative, and it's very fortunate that you got to get a gallium study and it showed that there was uptake there. The gallium study that you had was, I'm assuming, a gallium-68 PMSA study, which is specific for prostate, which tells me that these things are indeed prostate. And gallium works by a totally different mechanism than Axumin or carbon 11.
I have a question. If your PSA is above, let's say, 4.0, what is the best scan to detect? And if it's below 0.9 and below, what is the best scan to detect?
The question that, I think it probably all heard your, probably heard your question because the microphone. The basic question is if you have a PSA level of 4, and so the question I throw back at you, George, is has it gone to 4 fairly quickly, or is this kind of a gradual increase over time? So gradual, and it's worked its way up to 4, and assuming the patient is asymptomatic and can't point to a specific area to look at, I think the first scan we would still recommend would be a bone scan. If the bone scan is negative, we would go to what is covered, and that is Axumin. If your PSA level was 0.9, you said, and you're asymptomatic and it's been a gradual rise, the likelihood of you finding it with a bone scan is minuscule, so you would then want to go to one of the 3 fancier scans that are available, Axumin, gallium, or carbon 11. Axumin, the sensitivity between 0.5 and 1.0 is about 80%. So if you could afford it, go up to UCLA and get gallium, would be my recommendation. I don't think there's anything to choose between carbon 11 and Axumin. So in a perfect world, if we didn't have to pay for it, you go up to UCLA and you get gallium.
Okay, the Axumin, Medicare would cover the Axumin. The C11, it will not, and the price for that is like $3,000.
About $3,000. Yeah.
Okay. All right, yes.
I wanted to
Okay,
add-
yeah.
Can you comment on one other PSMA agent? It's the so-called 18F-DCF-PYL.
Yeah. Oh, you're still talking to me? As an attorney, you're still talking to me after what I said to you?
Wasn't a bad joke.
Yeah, that's right. Listen, by the way, my wife's family all lives in Michigan, so that helps me, doesn't it? That's a fluorine agent?
It's a PSMA agent.
But the question is it fluorine or is it still gallium? Because there's a couple of, yeah, I think they're both in the developmental stage. We have one that's being worked on by I think Blue Earth Diagnostics, which is a fluorine-based PMSA agent that looks like it's going to be pretty good, but it's just not here yet. So I don't think there's any head-to-head studies to show that it's better or not better. The longer the half-life of an agent, the easier it is to us to deal with, to do the imaging. That helps us. As far as the sensitivity, as long as the PMSA portion is good, it should be at least as good and maybe a little better.
Yeah, earlier you spoke about PSA doubling, okay, as an indicator for skin. I guess it's a relative thing. For example, I've been off the androgen therapy for years, and my PSA is monitored regularly. It's historically been less than 0.05. Now, supposedly it goes from 0.05 to 0.1. Is that would you consider it doubling, or it would be like from 2 to 4?
Yeah. The question's a good question, is how low do we go when we pay attention to the doubling time, especially in a patient who is on surveillance or maybe intermittent?
Well, I have radiation therapy, and I also have the androgen hormone
Right,
therapy.
but you're off now, the androgen.
My urologist decided, hey, let's take you off the hormonal therapy, and we'll monitor you every 3 months to see where your PSA level is. And like I said, historically, it's been all that time, it's been less than 0.05. It's a relative thing. If it goes from 0.05 to 0.1, which is a doubling, should I be concerned or not?
The answer to the question is you should be concerned, but not overly concerned, because you're not at a point at this where the urologist would be recommending treatment for you. They tend to like to follow you when your PSA is only at 0.1 and to just continue to check it for a while. If you start getting up to the 0.3, 0.4, 0.5, then they're going to talk to you about getting scanned. But at this level, even though it was a doubling, they tend to be more conservative and not push toward anything. So that's the philosophy we use as well at that lower level. If, like you said, if someone had gone from 3 to 6, we're going to jump all over that, because that's more worrisome.
Okay, I have a question over there.
Yeah, you mentioned the sodium fluoride.
Yeah.
What's the typical cost for that since CMS doesn't cover that?
The question is, what's the cost for a sodium fluoride bone scan? PET scans are typically in the range between $1,000 and $1,500, and that's whether it's FDG for tumor or sodium fluoride for bone.
All right, yes.
I talked to both a surgeon and a radiation oncologist about this looking for recurrence, and they both kind of poo-pooed it using the medical term, we don't do whack-a-mole. Are you finding that the surgeons and the oncologists don't necessarily care that you find recurrence because they don't want to chase it around your body?
Did everybody hear the question? Is it that some doctors have suggested we don't try to find something because they're not going to recommend whack-a-mole treatment?
Yeah, that was the term they both used.
Well, all the radiation oncologists I have dealt with in the community, which is almost all of them, like to do that, including protons. They all like to do that. And I do know if it were me and one site can be identified and that could have some cybernautry as a cure, potential cure, I'm going to do it. If you don't do it, you know it's going to spread and wind up in different places. Is there data to show that those people live longer than those that don't get whack-a-mole treatment? I don't know the radiation oncology literature for that, but that's the standard operating procedure with the radiation oncologist and the urologist.
Doctor?
Would be to treat it.
Would be to treat it.
Doctor? You mentioned, while you're looking up this, you mentioned that if you had spots on the bone and you were radiated and they figured that everything is taken care of, if you got another picture of it, it would still show those spots. I wonder if you can comment, does the bone metastasis produce cells that are monitored by a PSA test?
The answer is yes.
Thank you.
Metastases can produce PSA.
Thank you.
Any other questions?
Yeah.
Okay.
You're on antigen deprivation, ADT, and you go on vacation from the ADT because you get the low PSA. But then it starts to go back up again. Is that, like, could you wait till it goes up to 2 and then have the scan done to see where there possibly is, if there is possibly lesions to locate and then treat it? Is that what you do?
Yeah, the question is an excellent question, and that is, let's say you're on intermittent therapy or you're on a holiday, and your PSA had been, couldn't find it, less than 0.1. You've been that way for a year. You decide with your doctor that you're going to go on holiday, and then the PSA begins to go up. Do you make the decision to just go back on ADT, or is the PSA at a level where you would suggest to your doctor, should we scan and see if they can find it in me? And that's unfortunately a question in each individual we can't answer. So much of it is dependent on what happened in the very beginning, what your initial PSA was, what your Gleason was, what your form of therapy was, what the likelihood is that this is widespread disease or it's confined to a single area. It's a question that's worth asking, because a certain percentage of the time the doctor will say, well, you know what, that's a good thought. Your PSA is up to 2 now. We do have some studies where we might be able to find it. There's no risk for any of these studies. We can do it. If we don't find it, you're going back on your ADT, and that's the way we'll handle it. Or we know that in the beginning that the risk factors were too high. The odds are pretty good that this is systemically some cells around. We just want to put you back on your ADT since you responded to it before. You're going to respond to it again. Let's bring that PSA back down. So I wish I could, in your specific case, tell you, but it's a question worth asking, because in certain cases we do go looking for it again. In other cases, we just put them in back on the ADT.
Any questions? Okay, you're asked. Over there. All right, question.
Thank you. I apologize if you spoke about this because I missed the beginning, but I'm curious as to any of these scans that would be best for the ultrasound, not ultrasound. What can you give me?
The question is there, and I think I have the question right, are there certain scans that would be better to direct the person to high-frequency ultrasound as far as treatment is concerned? I think anything that actually can identify the lesion is going to be fine, and for something like high-frequency ultrasound, which is a way of focusing ultrasound treatment to take care of the tumor, you want the most precise anatomic study that you can get, not necessarily nuclear, because we're not as precise anatomically, and nuclear tends to spread out and make you think the lesion is bigger than it is. You'd want either an MR or a CT, most of the time MR, and that would then allow them to design their field based on the most precise anatomic location. Yeah, they would just want to, the standard MR may work or now what they tend to be doing is what we call multi-parametric, which is looking at both the anatomy and the function to see if there might be an area around the site of tumor that's suggested that even though there's not a major anatomic difference at that point, there could be some tumor cells in the periphery. So I think a multi-parametric MRI would be the way to go.
Question in the back.
Can I rephrase my question, doctor?
Sure, if I can rephrase my answer.
On the list of symptoms, I can get that from the record. There were a number of them that concerned me personally. How do you distinguish the significance of the symptoms? Do you do that with your urologist, or do you do it yourself?
And that's an easy question to answer without having us put those up again. And the question is, how do you figure out if your symptoms are meaningful or not? Typically what we do, since we're seeing our patients on a very regular basis, is we're looking for change. If these are things that are new, that have developed that weren't there before, or worsened, we decide we need to work it up. We need to evaluate it. If it's been there for months and it hasn't changed, we know it's a benign cause for that. We can take care of it. But we look for new symptoms or changes, and that's how we make our decision.
Any other questions? All right.
The question I had was before, I think you asked a question, that if you go off the ADT therapy, and then you see your PSA rise, okay, to what you consider unacceptable, or your urologist says, okay, it's up really high. You have a choice. Do I go back on the ADT, or do I select to do a scan? Would the safe bet to do is to do a scan?
Yeah, typically it's to do a scan, but again, you got to understand where that PSA is, whether the patient is symptomatic, and what their risk profile was going back to the beginning. A scan is, and that's why I suggested it's not a bad idea to ask your urologist, so what do you think now about doing a scan? Because first of all, there may be scans available now that weren't available when you were initially, not you, but when someone was initially evaluated. So it's a very reasonable question to ask the urologist in the hopes that you find a single spot that then can be addressed.
Okay, any other questions? There we go, Larry.
Doctor, could you explain a little bit more of something I've never heard of before? Prostate cancer making testosterone. If it's going on, news to me. Because my testosterone is going from 350 to 600 in the same 10 weeks that my PSA went from 32 to 43. So it's really an interesting thing to talk about there.
Yeah, the question is, prostate cancers, do they make testosterone? I've never heard of that. I don't know how that could happen.
I must have misunderstood that.
Maybe did they make they say PSA, maybe it's making
No,
PSA?
you mentioned it, but then you said testosterone.
Now we got there. No, you can make testosterone from other areas in the body, which ultimately can, can drive it, but it doesn't make testosterone. Prostate cancer cells do not make testosterone.
Okay, do we have this ready?
Yeah. Oh. I don't know. I'm going to give it one try by going forward here. We'll see. Here we go. It's the next one. So these were the signs of recurrence. If it's local, burning or pain during urination, difficulty urinating or trouble starting and stopping your stream, more frequent urges to urinate at night, loss of bladder control, decreased flow or velocity, and then blood in the urine. So again, if these are new, if these are worsening, we want to look at it. If there's any signs of metastatic disease, which is not very common, sometimes they would include the new development of erectile dysfunction or painful ejaculation, swelling in the legs or pelvic pain, which could be lymph nodes in the abdomen or pelvis that are being blocked off by tumor so that you can't drain from the lower extremities. Numbness, which could be due to bony metastases, which are impinging on nerve roots or the cord. Bone pain, which does not go away, which is persistent, or the development of spontaneous fractures. We would worry about that. Okay.
Well, let's thank our speaker, Dr. Kipper.